Hello, I'm Dr. Robert Parisian. I'm an orthopedic sports medicine surgeon at the Icahn School of Medicine at Mount Sinai. I provide team and event coverage for Team USA, US Ski and Snowboard, USA Fencing, as well as the NYC Marathon. And we're really here to discuss the management of the acetabular labrum, or the labrum of the hip. Some of my disclosures you can see here. I'm an associate editor for the Journal of Cartilage and Joint Preservation. I sit on the editorial boards of the Journal of Arthroscopy, Sports Medicine and Rehabilitation, as well as the Journal of Sport Rehabilitation. I'm also on the research committees for the American Orthopedic Society for Sports Medicine, the Arthroscopy Association of North America, as well as the Learning Center Committee for the Arthroscopy Association of North America, the Media Committee for the Society of Military Orthopedic Surgeons, and I'm also on the Board of Trustees for Athlete Soul. So getting into our discussion about the hip pathology and the layered concept. So the layered concept, as you can see here, is often discussed to describe hip pathology in the hip, whether it's intra-articular, extra-articular. And you'll see what we're discussing today will be the labrum. And one of the main purposes of the labrum is static stability. And the labrum can be found here in layer number 2 in the inert layer of the layer concept. Now looking at the anatomy and function of the acetabulum as well as the labrum. So this is an en face view of the acetabulum. And if you can look at my cursor here, this is the cotyloid fossa that is in the center here. The cotyloid fossa is devoid of cartilage. At the bottom here, you can see that there is an opening here. Why? This is where the transverse acetabular ligament lives. This is in the inferior aspect of the acetabulum. This is the lunate cartilage surface here. This is going to be the anterior aspect of the hip here, about the 3 o'clock position, and we come back here to the 6 o'clock. Up here is the 12 o'clock position in the acetabulum, and you can see the stellate crease. The stellate crease kind of helps us guide ourselves when we're inside the hip doing hip arthroscopy as to where the 12 o'clock position is. But again, this is the lunate cartilage that you can see. Right here, this is the superior aspect, anterior aspect, and posterior aspect. The labrum is right outside and is in conjunction with this lunate cartilage. And the labrum is right here. That wraps around 270 degrees roughly, because again, in the inferior aspect, you have the transverse acetabular ligament. This bottom structure just overlays the rectus. You have the direct head of the rectus here, attaching to the anterior inferior iliac spine, and then you have the indirect head of the rectus, which comes over into the 12 o'clock position. So moving forward in the anatomy and function. So if you look at this illustration, you have number 1 represents the capsular recess. So this is the capsular recess here. You have the capsule superficial to you. You have the acetabulum here. This is the cross section. So number 2 right here is the labral thickness that you can see. And 3 is labral width. Again, this is cross section. So the labral width is from the acetabulum to the outer aspect of the labrum, which that you can see here. And why are we discussing this? Well, the labral width is really what we talk about when we discuss what a normal labrum is versus a hypotrophic or a smaller labrum or a hypertrophic labrum. And typically a normal labrum has been considered to be in about the 4 to 7 millimeter range. Hypotrophic, smaller labrum, less than 4 millimeters, and then a hypertrophic, greater than 7 millimeters. Further anatomy and function, the chondrolabral junction is about a 1 to 2 millimeter transition zone. You can see here the transition zone with this sort of pink or orange circle. This is really a weak zone within the acetabulum at this chondrolabral junction. The acetabular cartilage thickness is about 1.26 millimeters thick. Looking at the anatomy and the fibers of the labrum itself, the posterior labrum, the collagen fibers are actually perpendicular to the acetabular rim, whereas in the anterior labrum, those collagen fibers are parallel to that acetabular rim. And this may create that vulnerability to shear stress in the acetabular labrum, and maybe why, or part of the reason why, we see increased tears in this anterior labrum. And then again, as we stated, the chondrolabral transition zone has a variable arrangement of fibers, so really is an area of weakness within the acetabulum. Now, the function of the acetabular labrum, it helps to deepen the acetabulum. It helps to increase the acetabular surface area. It helps to decrease contact pressures within the acetabulum. It increases the acetabular volume. It also has proprioceptive fibers within the labrum, as well as nociceptive pain fibers within the labrum. So this is a great cadaveric analysis that I wanted to mention and discuss by Dr. Safran and colleagues that analyzed the strains across the acetabular labrum during hip motion. They evaluated and they quantified the circumferential strain, and they found that greatest strains were compressive strains with peak strains at 90 degrees of flexion, adduction, and internal rotation. Now, why is that important? Well, the fader, flexion, adduction, internal rotation, is our anterior hip impingement test. And this is where they found the peak strains during this cadaveric analysis. This is a great video that I encourage you to look. I added the YouTube URL there, and again, this is done by Jorge Chala and colleagues, and they looked at the distractive forces and the suction seal of the labrum. Obviously, this is a cadaveric analysis, and they literally provided traction on that on the femur, and then they try to distract the femoral head from the acetabulum. It really demonstrates the suction seal of the labrum. So this was another nice cadaveric analysis, this one by Dr. Laprade, Philippon, Nepal, and all. And they looked at the effect of the acetabular labrum tears, repair, resections, and the reconstructions on the overall hip stability to distraction, similar as we were describing there to distraction. Then what did they find? Well, they found that chondrolabral tears reduced the force required to distract the hip. So when you had a chondrolabral tear, it was easier to distract that hip. The hip was more unstable. Now, if you had a partial or complete labral resection, the mean distractive force was reduced by 70%, 70% easier to distract that hip. And then when you repaired that labrum, you actually repaired the stability to the hip. Now, what can cause labral tears? What sort of pathology? Well, as you have on the left here, you have femoral acetabular impingement, FAI. You have different versions. You have a CAM type, a pincer type, or a mixed or combined type. Now, this is not going to be the focus of our talk, but of course, we'll touch upon this. The CAM type is when you have an asphericity of that femoral head, neck junction right here with this little bump. That's a CAM type FAI. Pincer is when you have over coverage, that acetabulum is over covering the femoral head. That's pincer. And then a mixed or a combined type is when you have both a CAM and you have a pincer type of impingement. Now, on the right here, you have acetabular dysplasia on this right hip, and this is a normal hip right here. So what is a dysplastic hip? A dysplastic hip is when this acetabular rim is not covering the head of the femoral head enough. And so you have an increased tonus angle, which is this represented by this purple line here. You have a decreased acetabular edge angle. This one would be a lateral center edge angle. And then in a false profile view, you can look at the anterior acetabular coverage. And in a dysplastic acetabulum, you'd have a decreased anterior center edge angle. And then you can also have and potentially see with an unstable pattern greater than 1 centimeter of lateral translation of that femoral head in relation to the teardrop, as you see here. And so this is a dysplastic hip, both in which the impingement and the dysplastic hips can contribute to chondrolabral pathology. Now, and this is how they do that. So it's important to understand if what is your inciting event? Is it a CAM type of impingement or a pincer, or is it a hip dysplasia? And why? Because with femoral acetabular impingement, you get this outside in type of lesion. And so when the CAM of the femoral head neck junction and flexion engages that labrum from outside in, you get labral damage and undersurface chondrolabral delamination is what we're seeing here. So that the labrum is being damaged, it's causing delamination of that adjacent articular cartilage on that lunate surface. And that's the outside in type of lesion that you get with a CAM type impingement pattern. Now, when you have dysplasia, you get a separate type of chondrolabral lesion. And why is this? Well, you have a vertical force vector here, and you get edge loading on the acetabulum and the acetabular labrum. You may see hypertrophy of that acetabular labrum. We'll discuss that in the next slide. But you have decreased coverage of your acetabulum. You have a vertical force vector edge loading here of your lateral acetabulum and the acetabular labrum. And you get damage to the acetabular labrum. And also, you get an inside out lesion created on the lunate cartilage surface. And that inside out lesion can cause flaps. It's not a delaminated lesion that you would get from the outside in type of FAI. This is an inside out. So you get flaps here of chondrolabral tissue or mostly of chondral tissue. And that's viable tissue, for example. Now, when I discussed the morphology and I mentioned the hypertrophic labrum, this was a nice study by the Anchor Group, which is really a collection of some of the leading hip preservation specialists in the world, and they evaluated what does the hip labrum look like in patients who have frank dysplasia. And so they this was a 10-center evaluation. They had 972 dysplastic hips that required a PAO, a periacetabular osteotomy for correction. So that's how dysplastic these hips were. Now, when they evaluated this, they found that 50% of these hips had a hypertrophic labrum. And that was associated with a decrease in lateral center edge or anterior center edge angle. So the more dysplastic that you were, the more likely you were to have a hypertrophic labrum or a larger labrum. Why? Because that was taking the force of the femoral head and it was increasing in size and surface area to provide stability to that acetabulum. Now, interestingly enough, that amongst these hips that underwent PAO, 45% demonstrated a normal labrum. And so they did not have labral hypertrophy, which shows that labral hypertrophy is not a universal finding. So just because you have dysplasia doesn't mean you're going to have a hypertrophic labrum. And furthermore, 4% actually had a hypotrophic labrum. So again, less than about 4 millimeters in labral width. And then 64% of these were associated with labral tears. Classifying labral tears and chondral damage. There are several classification systems, but I think the one that's most broadly used is the Beck classification. And you can see it down here at table 1 of the labral classification. You have normal, which is a macroscopically normal or sound labrum, a degenerative labrum, which is thinning or localized hypertrophy or fraying, a full thickness tear, which is a complete avulsion from the acetabular rim. You can have detachment, which is separation from the acetabulum and from separation from the labral cartilage. You can also have ossification of the labrum, which is the result of osseous metaplasia, either localized in one area or a circumferential osseous metaplasia throughout the entire acetabulum. And then as far as the articular cartilage classification is concerned, you have normal, malacia, debonding, cleavage, and defect. And then there are associated definitions there. And so the Beck classification, I think, again, is one of the most broadly used classifications. And this is a study by the Anchor Group, which looked at the reliability of this classification. So they had 4 hip arthroscopic surgeons that evaluated 40 arthroscopic videos, and they evaluated these videos on 2 separate time points so they could determine inter and intra rater or observer reliability. And again, they evaluated the anterior superior aspect of that of the acetabular rim, which is where we have the vast majority of our acetabular labral defects. And they found that the Beck classification provided substantial inter and intra observer reliability. So now getting on to the management of labral tears, and this is a nice Venn diagram that depicts the size in which or the volume in which we are treating these labrums with what type of technique. So repair and debridement are going to be overwhelmingly the largest amount of ways in which we treat and care for labral tears, especially in the primary setting. We'll get into the primary versus revision settings. Now, I would argue this augmentation circle is a little too large. That should be a smaller circle, and the debridement circle should be larger. But repair and debridement, again, are going to be the vast majority of the things that we do. Now, debridement is when you have adequate bony stability. Patients, if you have adequate tissue there, you're going to repair a labrum if you have a younger active patient, if it's a primary hip arthroscopy, if there's an unstable labral base, you want to stabilize that base with a repair. You need adequate tissue quality to repair the acetabular labrum. And then you're really trying to recreate that suction seal when you repair. So this is a nice evaluation by Dr. Philippon and his team looking at 10-year outcomes of labral repair versus debridement and FAI. And what did they find? Well, they found that hip arthroscopy for FAI with either debridement or repair resulted in significant improvements in function. And so both debridement and repair had significant improvements. However, they did find a higher rate of conversion to total hip arthroplasty in older patients with who were treated with acetabular microfracture. So why would you treat microfracture? Microfracture is a way in which you can stimulate the marrow elements to create a fibrocartilaginous surface in the lunate cartilage. And why do you do this? Is because you have cartilage damage. They also found increased total hip arthroplasty rates in patients who had less than 2 millimeters of joint space. And so again, when you have joint space narrowing in the femoral acetabular joint or any joint, then that is a sign that you have some cartilage damage, some cartilage thinning. So basically, you're at increased risk of a total hip arthroplasty if you have decreased quality of your cartilage going into your hip arthroscopy procedure. So labral repair. And when you look in the top left, when you prepare the acetabular rim with a burr, you want to try to expose bleeding bone. So here you have the labrum is here. This is the burr that's here, and this is the acetabulum. And you're trying to expose bleeding bone on this side of the acetabulum because this is where you're going to place your anchors for fixation of that labrum. Deep inside here, you can see the lunate cartilage surface here. Now, do not over resect, or be careful to not to over resect, because as we'll discuss in later slides, you can have a decreased width of your lunate cartilage surface superiorly that can lead to problems of over resecting for a pincer lesion, for example, and you don't fully appreciate what your acetabular morphology and true coverage is. Now, suture anchors are used for varying materials and varying designs. There's also different techniques that you can utilize. Here you see in the bottom right, this is a simple loop technique that I've utilized here. You can also do a base refixation, which is a vertical mattress type of technique. You can have everting or inverting repair techniques. But basically, the overall goal here is to reestablish the labral base to stabilize your chondrolabral junction. And ultimately, you want to restore that suction seal. Now, this is why I discuss not resecting too much or understanding the morphology or the anatomy of your acetabulum before you're doing these procedures. This was a wonderful study that was done out of Boston Children's Hospital. And if you look at B, this is the control group. This is a normal acetabulum. Again, in the middle here, just to get ourselves oriented, this is the cotyloid fossa where there's no cartilage. This is the lunate cartilage surface. This would be anterior, superior, posterior is how we'll define it here for anterior and posterior. This is a dysplastic hip, so you have decreased cotyloid fossa as well as decreased width of your anterior, superior, and posterior lunate cartilage surfaces. These C and D are both deep, so this would be like a pincer type of impingement. We have a deep acetabulum. Now, subtype 1, which is C, you have a normal cotyloid fossa here. You have a normal width of the superior lunate cartilage, but you have larger anterior and posterior lunate widths. That's where you're getting your extra coverage from, is anterior and posterior. Now, subtype D, you actually have a deeper socket because the cotyloid fossa is larger. The cotyloid fossa is larger. Anterior and posterior lunate articular surfaces are normal in width. However, the superior lunate cartilage surface is decreased in width. So if you have a subtype 2, which is represented here by D, over coverage or deep socket or deep hip or deep acetabulum, representing a pincer, and you go and you resect that superior acetabular rim, you could be creating some instability laterally because you have decreased lunate cartilage here, and you're going to be thinning out this area and creating increased contact forces on that remaining small surface area of lunate cartilage that you have. So you got to be very careful and understand your anatomy and morphology. And so this is a video of me preparing the acetabular rim. This is the acetabular rim here. This is our capsule behind us, and this is the labrum to the right. And this is preparing the rim, trying to get it to a bony bleeding surface. Be careful not to resect too much acetabular rim so that we can place our anchors here and visualize appropriately when we're placing our anchors. Again, the labrum is here. The capsule is behind us that I'm protecting with the sheath and debriding and burring this acetabular rim. And so now we place the anchor in the acetabular rim. This is the acetabular labrum here. This is a knotless technique, but you can have knotted anchors as well, but this is a knotless technique. And you can see here, the suture has already been passed, and we're shuttling the suture down, and it's going to cinch that labrum in a simple loop suture repair technique. And it tightens the labrum and it stabilizes that labrum against the acetabulum. And then after the repair, you can see the looped suture repair here, loop suture repair here, as well as over here and more anteriorly. This is the iliopsoas U region. This is the lunate surface down here. And I'm just demonstrating with my probe that you have a stable labrum now and a stable chondrolabral junction and a stable repair. Now, what are the outcomes? There's a lot of studies out there that discuss outcomes, but I chose these three, which are representative samples, I felt. So to return to sport, RTS is return to sport. 94% of recreational and 88% of high-level athletes were found to return to sport. 95%, that middle study of professional baseball players were found to return to sport. They had a mean career length of 3.6 years after returning to play after their hip arthroscopy. And then that bottom study, 87% of professional football players are putting a lot of stress and strain on this hip and a lot of stress and strain on that labrum. 87% were found to return to play. Linemen, a bit less likely to get back. Now, repairing a hypotrophic labrum, I want to touch on this because the literature is mixed. So that study on the left, and these are both high volume centers, a study on the left that found inferior outcomes of repairing hypotrophic labrum, whereas a study on the right, where they compared normal and hypotrophic labrums, after repair, they found similar outcomes. So again, mixed results still, and the jury is still out on the repair of hypotrophic labrums. Now, the wave sign, we'll get into exactly what the wave sign is in a second, but the wave sign is an important thing to discuss because, and this study evaluated it, where they looked at surgical outcomes of patients identified to have a wave sign without an associated labral tear that were treated with and without stabilization of the chondrolabral junction. And then ephemeroplasty, which is the burring of the femoral head neck junction cam lesion. So this is a wave sign. Up top, you have my probe. This is the labrum that I'm pushing down on here. This is the lunate cartilage surface, and this is the wave. And so you have delamination of the lunate articular cartilage here. So when I push down, you see that wave, that delamination. So it's bouncing, and there's a little bit of a wave there, as you can appreciate when you push down. So there's delaminated cartilage on the other side of that caused by an outside-in impingement type of lesion. And so this study that we evaluated this said if we look at that wave sign and we stabilize that, even though there's no frank labral tear, what do we find? Well, they found that chondrolabral stabilization in conjunction with the femoral osteoplasty is an effective treatment of patients with the wave sign. And so stabilizing that chondrolabral junction was very important. Now, the everted labrum, important to discuss because this is a native variant that was recently described. The authors of this study concluded that the everted labrum is a native variant identified during hip arthroscopy by assessing the labral seal when you're out of traction. And so this is a pictorials from that actual study. A and B at the top, just to orient, this is the labrum here. This is the labrum. This is the acetabulum. This is the lunate cartilage surface. This is the femoral head. The star here represents that uncovered acetabular rim. So this labrum should be sitting on that acetabular rim. This is the everted. It's everted here. So it's not providing that suction seal off traction. This is off traction. When the femoral head is sitting in the acetabulum, it's not providing that labral seal. This is off traction. So you can see the separation and the eversion. So what did the authors of this study do? They went and they repaired this labrum in an inverting fashion, placed their suture anchors here. They passed their sutures around the labrum and they inverted that labrum, brought it back to the rim of the acetabulum, providing, again, off traction, that suction seal. So important thing to note that this native variant exists. So moving on, so we've discussed labral debridement and repair. Let's get into reconstruction and augmentation. So labral reconstruction was first described by Dr. Philippon in 2010 and colleagues, and they used a iliotibial band autograft for their reconstructions. Now, the vast majority of these in the primary setting and in your practice should probably represent about less than 1 to 3% of all your cases in the primary setting, maybe less than 5% of your very high volume hip arthroscopist in the primary setting, again, the first arthroscopy. Now, these are performed for if you have an irreparable labral tear, if you have an ossified labrum that we discussed previously in our Beck classification, if you have a severely hypoplastic labrum, so you don't have enough labral tissue to repair. And then in the revision setting is typically where you're going to be performing a labral reconstruction. Now, this is what a labral reconstruction looks like. This is the labral allograft or autograft. This is the capsule up here. This is the femoral head. And then down here, we can see the lunate cartilage surface. And the probe is coming in to assess the stability and the repair of this, or the reconstruction rather, of this acetabular labrum onto the rim of the acetabulum. Now this next video demonstrates the suction seal provided. So in traction, out of traction, that femoral head's coming back within the acetabulum. It's showing the suction seal created by that reconstruction, by that reconstructed labrum. In traction and now back out of traction. So there's data out there, and but it's evolving, and there's not a lot of it with regards to primary circumferential acetabular labral reconstructions. And again, typically, as I said, this is done in the revision setting, but we do have some data that's coming out. I would say that there's a paucity of data at this time. The literature is still evolving. And so we clearly need some more level 1 and 2 studies with longer term outcomes to really truly understand what the role is in the future of labral reconstructions in the primary setting. Now, labral augmentation, also described by Dr. Philippon. Labral augmentation is when you take a graft, autograft or allograft, and you augment the existing native labrum that is there, the macroscopically preserving that labrum, that healthy native labrum. And Dr. Philippon found that in patients with previous procedures, the labral augmentation technique with preservation of the macroscopically healthy native labral fibers resulted in significantly better outcomes compared with a segmental labral reconstruction where damaged or previously removed labrum was replaced by graft. So again, labral reconstruction, you remove that native labrum, you place your graft on the acetabular rim. Augmentation, you leave the native labral tissue, you place your graft, and you incorporate that native labral tissue into your autograft or allograft. And that's what augmentation again. Now, again, paucity of data at this point in time, evolving literature, and we clearly need more higher level studies with longer term outcomes and follow up with regards to labral augmentation to fully appreciate, again, its role moving forward. So thank you for your time. Again, I'm Dr. Robert Parisian from the Icahn School of Medicine at Mount Sinai. You can see how you can reach me there via email, on Twitter, Instagram, as well as YouTube. Thank you for taking the time tonight to discuss and learn about management of the labrum of the hip. Thank you.